Hi, this is Chapter 3. It's Vital Signs and Hypertensive Urgency and Emergency. So this is going to go along with DH111 Preclinic. Also has a chapter on vital signs. So between the two, you should have a good review and a good knowledge of it. We'll be taking vital signs on every single patient. So this is something that you will learn and use on a consistent basis. So accurate taking and recording of vital signs is essential. So we do this before we treat anyone. If their vital signs are too high, we may reschedule them for another day. It may also depend on what kind of anesthetic we give them if they wind up needing a deep cleaning and need to be anesthetized for that. And it's also a baseline. When an emergency happens, you can look back at prior appointments and see if this kind of what they run normally and get an accurate reading of kind of how they roll. So the vital signs determine the body's ability to pump blood and breathe. It also determines the health status of the patient. There's 4 vital signs like we talked about prior in another chapter. There's pulse, respiration rate, blood pressure. Temperature is one, but it's definitely not taken, like I said, in all offices. It wasn't prior to COVID-19. It is being taken everywhere in offices now. Smoking is considered the new 5th vital sign. Weight is mainly taken in a pediatric office on children. It is taken in some offices for adults, but not considered a traditional vital sign. Pulse is the speed of the heartbeat, and it's the expansion and contraction of artery as blood is forced out of the heart muscle. So it's felt where the artery lies close to the skin surface and is compressed over hard structure, bone, or muscle. Usual sites are the carotid in the neck, the radial pulse in the wrist, brachial pulse in the arm, and femoral pulse in the groin. So what we will always do in the dental office and in most medical offices is take the radial pulse, and that's right at the wrist. If the carotid is used, if there is a dental emergency and you can't maybe get to the wrist or they're unconscious, very often you will use the carotid in case of an emergency, and possibly that will be a quiz question. Brachial pulse in the arm is sometimes felt in children. So the most common site, like I say, in the dental office is the radial pulse of the wrist. This is a picture of someone taking a pulse. Normal pulse rates in a healthy adult is 60 to 80 beats per minute or 60 to 100. So it's those who exercise really regularly tend to have a lower pulse. If you're more fit, you will have a lower pulse of possibly 40 to 60, and that's considered normal. And some of the books will say 60 to 80, some say 60 to 100. We kind of go with 60 to 100. RR is respiration rates. It's the number of breaths in a minute that you take, and a breath is considered breathing in and breathing out is one breath. So it's the rise and fall of the chest. An adult normal rate is 12 to 20 respiration rates. In infants and children, the rate is much quicker, and I think that might be a quiz question also. Little children's beats are very rapid, newborns very rapid, and then they lessen and lessen as the body grows, and so it's still a little faster in children than it is in adults at 12 to 20 rates per minute. Newborns, like I'd say, is like 40 to 50. Respiration rate, apnea is the absence of breathing. A lot of people have sleep apnea where they will not be able to breathe. Everything closes off and it closes and they don't take a breath and don't take a breath and don't take a breath and then all of a sudden take a huge breath. And a lot of times accompanied by noises, etc. So if this continues, if apnea would just continue and they wouldn't take that breath ever, it would of course result in death, respiratory arrest. And so the brain does require oxygen to live, and oxygen deprivation of 10 minutes or longer leads to coma or death. We call that brain dead within 10 minutes. You have over 5 or so, 3 to 5, you can start having some serious shutdowns of organs and serious problems, but may not completely cause death until it's more like about 10 minutes and they're brain dead. Respiration. Immediately following the pulse, we take the respiration so the patient's unaware and is not controlling their breathing. So if you tell a patient, I'm going to take your respiration now, they become acutely aware of every breath they're trying to breathe like they think you want them to, which very often is not a normal breath in and breath out, which is what we want. So right after the pulse, we'll move the patient's arm over, like that we took the pulse on, over their stomach. We'll take their opposite arm, move it over their stomach, and we will take the pulse. We will continue as if we're taking the pulse, but what we're really doing is counting the number of times the patient's chest rises in 30 seconds. And so rises and falls in 30 seconds, and then we will multiply that, by 2. Turn this off. If respiration is irregular, count respirations for 60 seconds. And by irregular, it means that you have a normal breathing pattern to where you breathe in, breathe out. If your breathing in takes, 2 more seconds than normal, and then all of a sudden when you breathe in, you're going like anything that's irregular than just normal, easy breathing in and breathing out. If that would happen, you'd want to take that for at least 60 seconds so you could see in a minute's time how much deviation there is to their breathing. So we'll just hold it like this. Respiration should be quiet, automatic, effortless. If there's abnormalities involved, there could be some noise or effort. Dyspnea, DYS in front of a word means difficulty or labored, and pnea, of course, means breathing. So someone with dyspnea has labored breathing, difficulty breathing, usually require a little oxygenation. Noises on the quality, you hear stridor. I'm sure you've heard that word before, stridor and wheezing. Stridor is another word for crowing. It's a harsh sound on inspiration. So they're taking a breath in and you hear some crowing sounds, and that would be called stridor. It's associated often with obstruction. And wheezing is really high-pitched sound on expiration or inspiration, and usually is associated with asthma. If someone takes a lot of deep sighs, it's a deep inspiration and prolonged expiration on a big sigh. You would need to note that if that's what they're doing a lot of. So factors affecting your respiration, your age could affect it, medications that you're taking, stress, exercise, altitude, your gender, and your particular body position. All of that could affect the respiration. Temperature, the normal temperature is 98.6 Fahrenheit, as we all know. It's the measure of heat associated with the metabolism of the body. That's what your temperature is. Pyrexia is another word for fever. It's an increased temperature, infection, neurological disease. It could be malignancy. It could be associated with congestive heart failure, trauma of some kind, drugs. Convulsions or delirium may occur with extremely high fevers. If you remember the word like pyromaniac is P-Y-R, it starts that way, a person that is in love with fires. And so pyrexia, exia means the blood, and so it's the fever, the temperature of the blood, pyrexia. Okay, so hypothermia is a reduced body temperature. Thermia means temperature, and hypo is less than, so it's less than normal temperature, which means they're going to be shivering, maybe cool skin, maybe their pallor is changed. Hypothermia causes, it could be illness, trauma, malnutrition. You could have hypothermia. Medications. If someone has that on a consistent basis, you should refer them to an MD. And one thing that will be coming up all the time is the word etiology, or plural is etiologies. It means cause. What's the cause? What's the etiology? Blood pressure. Blood pressure is the force of blood exerted against the blood vessel walls. So when the systolic is the force of blood against the blood vessel walls during contraction, ventricular contraction. When your heart contracts, it forces this blood out, and the force that it's coming out against the wall of the blood vessel is the top number, the systolic. It's the very first sound heard when you're deflating a blood pressure cuff. And the systolic over diastolic for normal would be less than or equal to 120 over 80. Diastolic. Diastolic is the force of blood against the vessel wall during ventricular relaxation. It's usually somewhere to 60 to 80. So if it's less than 60, that should signify, worth talking to the dentist about. If it's way over 80, especially if it nears 100, it's very dangerous, because that means that it's forcing the blood against the blood vessel wall very hard, even while your heart is relaxed. So that's something to take note of for sure. The diastolic is the last sound heard when deflating the blood pressure cuff. The pulse pressure is the difference between the diastolic and systolic. So higher and lower indicates cardiac abnormality. So usually if you take 120 over 80, you would just minus that. You take whatever the diastolic is away from the systolic, and then you'll get a pulse pressure in millimeters per mercury. So in this case, we would take 120, which is the systolic, minus the 80, which equals to 40. And if the pulse pressure is between a 30 and a 40 millimeters per mercury, that is fine. It's perfect. But higher or lower, that could indicate some kind of heart abnormality. Blood volume. Blood volume is additional blood or transfusion, increases the blood pressure. Reduction in blood is hemorrhage, decreases the blood pressure. So if you're hemorrhaging somewhere in your body, your blood pressure is going to fall. So if you get additional blood volume in your body from a transfusion, like we say, it will increase. The viscosity of the blood is how thick it is. If something is very viscous, it's very thick. Increased thickness causes the heart to contract more forcefully, and so it's going to increase the blood pressure. You got really thick blood, and it's increasing someone's blood pressure. They are going to probably advise the patient to start taking blood thinners, so it's not so hard for the heart to work to get the blood out. Cardiac output is how much blood is being forced against the blood vessel walls. It is whether it's during ventricular contraction or ventricular relaxation. It's just the output of the blood, how much is being forced out against the blood vessel walls. Blood vessel resistance, it has to do with the elasticity of the blood vessels. So if your blood vessels are nice and healthy, it's going to flow and you're not going to affect your blood pressure at all. If your blood vessels, you have atherosclerosis, and it's hardening and thickening of the blood vessels, then it's not elastic anymore and can't like ebb and flow. It can start to increase the blood pressure because it's taking, it's just, they call it resistance because not as much blood can get through in a normal way. Age can have an effect on blood pressure because the elderly higher blood pressure due to atherosclerosis, mainly in the elderly. Gender, men and postmenopausal women have so far usually had a higher blood pressure. That has been, women have been gaining on that throughout the last few decades for sure. Stimulant. If you take a stimulant, that can affect your blood pressure. Stimulant meaning caffeine, nicotine. That's all going to increase your blood pressure a little bit. Exercise, immediately following exercise, there's an increase in blood pressure because of how hard it's taken for your body to do the exercise. But people who have consistently exercise will all have a lower overall blood pressure because they do it on a consistent basis, and your body is used to that, and it will go ahead and have a lowering effect. Here's taking of a blood pressure. You see the arm level. Here's a blood pressure measurement. You can see here that there's a deflated cuff at the top picture on the right, and your brachial artery opening, it's going straight, it's being able to flow straight through. Then the cuff is inflated and is squeezing down, and it's squeezing that artery closed. So at its highest. So when you gradually deflate the cuff, which means you're letting air back in, the artery begins to open again, and it's that force against the blood pressure wall after it's been closed. So you can see here that it's the axillary artery coming from the aorta, looks like, in the heart that comes down. It's the brachial. It's going to split into the radial artery and another artery, and right there at the brachial artery is where you're going to be taking the blood pressure. The process is you place the blood pressure cuff on, and you place the earpieces in your ears, and the earpieces slant in one direction, and you want to put the earpieces facing toward the tips of the nose. So it kind of goes in exactly opposite of what you think would be comfortable, and we'll be doing this in clinic, so you'll know. We're going to locate the radial pulse, and then we're going to close the valve on the blood pressure cuff. We're going to inflate the cuff with the hand control bulb until the radial pulse is no longer felt. We want that pulse to close. As soon as the pulse can no longer be felt, then we want a manometer reading, and we take that and inflate it 20 to 30 millimeters per mercury higher. Then we're going to deflate the cuff gradually, at least 2 millimeters per mercury at a time. You're going to listen for the first sound, which is the systolic reading, and you continue to release slowly at about 2 millimeters per mercury at a time. Listen for the last sound, which is the diastolic reading. And all of these sounds heard during the taking of a blood pressure are called Korsakoff sounds, and I would know that. developed, named so by, I don't know if he was a doctor or not, but there was a man called Korsakoff who introduced these sounds. Then you're going to have a release of all air. You're going to record the blood pressure in the patient's chart. If you're unsure of the reading, then you're going to wait you can wait 30 seconds and retake a blood pressure, but in the clinic, per the dentist's approval of this, we usually wait about 5. We just want the blood vessels to go back in their normal place before we retake a blood pressure. So hypertension. Hypertension is high blood pressure, or HBP. It's a disorder that is characterized by elevated blood pressure, higher 140 over 90 and higher. So if a person's ASA is perfect, they are not taking any medicine, they don't have a cough, they're not prone to any, they have no disorders in their body, they're perfect, except when you take blood pressure, it's 140, it's going to immediately throw them into a higher ASA category. So it's the most common primary diagnosis in the United States, hypertension. 60 million Americans, they say, are affected, and that was at the time of this book, so I'm sure that there's more now. 70% of the people, they say, are unaware. They don't take their blood pressure on a regular basis and are unaware they even have hypertension. So this is a good way for hygienists when we take their blood pressure. We have been able to alert a lot of people who may not have had the luxury of going to a dentist throughout their life, and so this is the one place that they can get their blood pressure taken on periodically every time they come in. So normal would be less than 120 over less than 80. I know that first one said less than or equal to 120 over 80 for normal. And it's actually, we need to take the equal sign out. It's less than 120 over less than 80 would be normal. Pre-hypertension is when a person's blood pressure is between 120 and 139, or on the systolic and diastolic 80 to 89. The diastolics always jump by 9. You can see 80 to 89. And then it will go stage 1, 90 to 99. And these always drop by almost 20. It's like 120 to 140, like -1. It's like 19. This is 140 to almost 160, which would be 20. But it's 159, so that's 19. So they consider these normal pre-hypertension, high blood pressure, stage 1, and stage 2 on the high blood pressure. So if let's say that their systolic was only about 130 and their diastolic was up here at this 92, then we would still call that stage 1 hypertension because the diastolic is over what it should be. And in that range, sorry. Okay, the stage 2 hypertension would be anything over or equal to 160 and over or equal to 180. That's stage 2 hypertension, and we always need to you'll get your instructor in the clinic, but you will always need to consult with the dentist. That's what we're going to do, is consult strictly with the dentist at that rate. It is in our dental hygiene catalog that this must be done, to consult with them and try to figure out if we're going to treat them or not. Sometimes we do, and sometimes we don't. So systolic is 120 to 139 millimeters per mercury, and diastolic 80 to 89 millimeters per mercury. Stage 1 hypertension is 140 to 159 millimeters mercury for the systolic, 90 to 99, like we talked about, for the diastolic. You just advise this person, if they have this and they're worried, to advise a healthy lifestyle, maybe say refer to an MD. You don't have to, we don't want to scare people and have them pay for doctor visits that are nothing. They could have rushed here. They could have eaten something spicy before they came here. They could have, run up the steps instead of taking the elevator. They may have been late, and so they're all, excited, and adrenaline is pumping and the heart is pumping a little faster. It could be for some kind of medication, etc. So we don't want to scare somebody to death over that and have them go needlessly. To an MD, we're just going to advise them to try to keep a healthy lifestyle, and next time that they are at a doctor visit of some kind, to let the doctor know. So oftentimes, even at this rate, they will place the patient on an antihypertensive medication. Stage 2 hypertension starts at 160 or higher, and the diastolic 100 millimeters per mercury or higher. So this is without prior end organ damage. We would recheck the blood pressure to make sure that we didn't make a mistake in what we were hearing, and then refer to an MD. So if they do have prior end organ damage, we would check the blood pressure and immediately refer to a medical evaluation. And we would give them no additional treatment that day. So end organ damage means that if you have 160 over 100, but you don't have anything else, you don't have an organ in your body that is damaged in some way or not working correctly, liver, kidney, lungs, etc. So you may recheck it, maybe go ahead and do the treatment, refer them to an MD, take the advice of your dentist on what to do in that situation. But if they do have end organ damage, you're just going to recheck their blood pressure, make sure you're correct, and immediately refer them for an eval. Hypertension in children. Hypertension in children are determined by sex, age, and height. So of the child, you're going to use the chart to determine what that is, and I will just say on there that the and turn to that page. On page 32 and 33, it has all those charts for blood pressure when you are in an office, but we don't see many children. We don't have those type of procedures for children. So instead of trying to memorize this whole chart or anything, all you really need to know, and the questions I see that come up on boards and on your tests, will be what is the normal range. A normal range for a child, which we determine by their sex, whether they're male or female, and their age and their height, is it needs to be at the 89th percentile and lower. So that's the only thing I ever hear about that. If you just remember 89th percentile and lower is a normal range for children, and it's by sex or gender, age, and height, not weight. So then we get into hypertension urgency versus hypertension emergencies. These are the first of our comparison dental emergencies. So hypertensive urgency is when they have extremely high blood pressure reading, but they don't have any of that target end organ damage. So types of target end organ damage, you could have an aortic dissection, cerebral infarction or hemorrhage, myocardial infarction, or a renal insufficiency. Renal is your kidney. Patients in scenario 2 in your book have the hypertensive urgency. So the treatment, these people usually speak normally, even if they're hypertensive urgent. We recognize the sudden increase in blood pressure greater than 180 over 110. 110 diastolic is extremely high. You're going to wait, retake the blood pressure, make sure of your numbers. They could be having headache, anxiety, shortness of breath, edema, which is swelling, and epistaxis, which is bloody nose, or tinnitus, which is ringing in the ears. So you want to seat your patient upright if they're conscious and contact EMS. You want to monitor their blood pressure every 5 minutes and be having someone take that reading every 5 minutes until EMS can get there. You may want to administer 4 to 6 liters per minute of oxygen if they complain of difficulty breathing or dyspnea. Hypertensive emergency. This is extremely high blood pressure again, but with target end organ damage. So it was formerly called hypertensive crisis or malignant hypertension, and now they call it hypertensive emergency. The symptoms are similar to an MI, myocardial infarction, or a cerebrovascular accident. They're difficult to determine the exact emergency. They can mimic each other at that point, but it's when there's a sudden increase in blood pressure greater than 180 over 110, and sometimes even as high as 220 over 140. So at that point, they're definitely going to have dyspnea, chest pain, dysarthria, and that means difficulty speaking, weakness, seizures, visual loss. They could have nausea, vomiting, and eventually go into a coma. So what do we do to treat them? We want to recognize sudden increase in their blood pressure, which you definitely would. Recognize dysarthria, headache, or anxiety. You're going to call EMS. And when the EMS comes, they're going to treat the end organ damage first. So if the blood pressure went high out of this world because the person is experiencing a myocardial infarction, they're going to take care of that first. Or a cerebrovascular accident, they're going to take care of that first, which ultimately will help to bring down the blood pressure. So they go to the actual cause. They're going to treat the hypertension secondarily. So you want to seat the patient upright, have them breathe, monitor the vital signs until EMS gets there about every 5 minutes. Take the number down, administer oxygen 4 to 6 liters per minute, and CABs if needed. And you only administer the oxygen if they're having dyspnea or you feel that they need it. Hypotension is less than normal blood pressure, so the blood pressure is not adequate for perfusion of blood and oxygenation of all the body tissues. Usually there's a reduction in the baseline systolic or diastolic blood pressure of like maybe 15 to 20 millimeters per mercury, which is quite a bit. So if they normally have a 140 over 80, they could now be having a 120 over could be 60, and it's not their norm. If you go back into the notes in Dentrix, you can be able to find this out pretty quickly. Often it's caused though by medications. Often happens in the elderly, who by far usually take more of the medication. So they need to get some kind of a antihypertensive medication from their doctor, because this type of activity can eventually lead to shock. But what we can do until EMS gets there, which we're going to contact them, we're going to position the supine, the patient supine with the feet raised, and it aids in getting blood and oxygen to the brain. So we call it the Trendelenburg position, to where the head is lower than the heart and the feet. So we just, in our type of chairs, we can do that pretty easily. If this happens with someone outside, then you're going to lay them supine. So you want to be able to always assess their airway. Anytime there's a medical emergency, we want to secure the airway. So you want to may have to administer the CABs, administer oxygen possibly 4 to 6 liters per minute, monitor their vital signs, and if no improvement, contact EMS. So orthostatic hypotension. Orthostatic hypotension is a postural hypotension. So it's sometime when you are squatting down and you get up too fast and you feel very dizzy, or you've been laying down too long or sitting in a certain position too long and you get up too fast. And this is usually your body has to be able to level out a little bit, and it's usually from a supine to a sitting or standing. So if you think about it, our chairs in the clinic are automatic. We can't just lower them and raise them at the rate we would want to. It just does it on its own. And for some elderly people, they feel like that's way too fast. And so we want to let them sit in the chair for a few minutes until everything all equals out in the system, and then have them stand up because they could easily fall. So dizziness or loss of consciousness may occur, illness, and normally hypotensive individuals, those with really low blood pressure, could have orthostatic hypotension easily, and those that are on anti-hypertensive medications. Maybe it's a little too much and it's causing a too low of blood pressure. So symptoms that you're going to need to remember is with orthostatic hypotension, there's a dimming of vision. You don't see cross or anything. It's just that there's just a slight dimming of the vision, and that's the main symptom of orthostatic hypotension. Decreased hearing, lightheadedness, it's way more common in those who, like I say, already have low blood pressure, and they're going to be breathing slower. So usually you just need to let them stay in one position and not move up or down, and in a couple minutes, usually everything comes back to normal.